I've had the privilege and pleasure of working with patients with MS for the last 8 years. It's, I think, a very rewarding field. There are a lot of needs that they have, and you get to know them over the years, you get to form relationships with them. So it's very rewarding in that sense. And also, the field of neurology in general, and MS in particular, has advanced a lot. Used to say diagnose and diagnose, but that's fortunately no longer the case. We have a lot of treatments, and let me tell you about how this came about. I work closely with the National MS Society, and one of our goals for the year was to reach out to physicians and spread information about MS to physicians. We do a lot of patient education programs, and this is one of our other goals, to educate other healthcare professionals. So thank you for allowing me the opportunity to do that. So this is titled MS Disease Overview for Primary Care Physicians. At the end of this, well, before we get there, let me talk about my disclosures. I forgot to add the slide, but I'm a speaker for Teva, Biogen, Genentech, and Novartis, all of whom make various products that are used for the treatment of MS. But I'm going to not discuss any. I'm going to discuss pretty much all the products, and everything I'm going to say is on label. So at the end of this, you should be able to recognize and monitor MS symptoms and manage the primary care needs of the patient with MS, and describe diagnosis, treatment, and multidisciplinary management of MS. And I will provide a list of some resources available through the National MS Society. We'll start with your role as primary care providers, and then we'll talk about MS in particular. What's the pathophysiology? What are the risk factors? How do we diagnose it? What's the disease course? How do we treat it? And symptoms. So the role of the primary care provider is early recognition of MS symptoms to facilitate timely diagnosis, and then ongoing monitoring once the diagnosis has been made. We know there's a diagnostic delay of a few years from the time of onset of symptoms till the time of diagnosis, and there are many reasons for this. MS is a condition that occurs in young people. They often feel invincible and they fail to seek medical attention. The symptoms can be transient. So sometimes they'll make an appointment and their symptoms resolve, so they don't follow up. Or the symptoms may be relatively mild, they just don't seek attention. Sometimes the symptoms are attributed to another cause, falsely. And sometimes it's just difficult to diagnose. Sometimes people need to follow up a few times, and they need various tests, and some people get tired of this and just stop following up. So remember to refer to neurologist if the patient has any neurological symptoms that you think might be related to MS. Remember, common symptoms of MS, common early presentations would be optic neuritis with painful vision loss. Usually they'll complain of pain when they move their eye. Patient may say, it looks like I'm looking through film or plastic or water, and they may lose the sensitivity to colors. This can be unilateral or bilateral, and most cases of MS are relapsing, so these symptoms can evolve over a few days or a few weeks. Other common symptoms would be transverse myelitis, when they will present with weakness or numbness in both extremities, usually both lower extremities. It can involve the upper extremities also if the cervical area is involved, and it can involve trouble with bowel and bladder function. They can have brainstem syndromes like internuclear ophthalmoplegia, which is classic. They will have double vision on lateral gaze, binocular double vision. So these are some classic symptoms. If you see those, refer them to us. And anytime you have a suspicion, that's fine to refer to us. We would rather tell them you don't have MS than they should follow up 10 years later and we tell them, oh, really, you had MS 10 years ago. So that we'd rather get more patients who we can then tell you don't have MS. That's okay with us because it's important to catch it early. And then throughout the course, you'll refer to neurologists, mental health professionals, urologists, rehab specialists, and others. These patients are very complicated and they have a lot of care needs, as I mentioned. So as a team, hopefully we can work together, and what would be ideal for us would be if patients get their age-appropriate screenings for cancers and so forth, if they're counseled about smoking cessation, vitamin D supplementation. We do a lot of this ourselves, the smoking and the vitamin D supplementation, but the age-appropriate screenings we would rather refer. We do mention to patients that you should have this and that, but they don't always follow through with it. So we would appreciate your assistance with that. Also, vascular comorbidities need to be diagnosed and treated effectively. We know vascular comorbidities can lead to worsening of MS, secondary progression. We'll talk about that more. Bone health is important. Many MS patients are unable to be very active and they can develop problems with bone density. And skin health also, especially in those who are wheelchair or bedbound. Also, we would want your help with appropriate vaccinations. Influenza, hepatitis B, varicella, and tetanus vaccines are safe. Any inactivated virus vaccine would be safe. Live virus vaccines are generally not recommended. And there are online resources to help guide your decisions on vaccinations. Please communicate with us if the patient is having any new symptoms once they're diagnosed. This could be a relapse or it could be progression if they're having worsening symptoms. Anytime a patient calls us or comes to us asking about worsening symptoms or symptoms that have come back, first thing I think about is there an infection? We know people often have pseudo-relapses, and when they have an infection, old symptoms can come back or current symptoms can get worse. So we always ask, do you have an infection? And if not, then we might treat it as a MS relapse, unless there's some other cause. So please monitor their symptoms, mood problems, problems at work, trouble sleeping, cognitive changes. We ask about those things as well. Some of these things are harder for us to manage, like pulmonary function and such. We need help promoting adherence with disease-modifying therapies. And as I mentioned earlier, identifying and addressing comorbidities, especially vascular ones. And complex symptoms such as pressure ulcers and osteoporosis and such need to be managed together. Again, there are some resources on the MS Society. They have a National MS Society has a comprehensive website. I refer all my patients to their website, and they have sections for professionals and patients as well. So what is multiple sclerosis? We know it's an immune-mediated disease of the central nervous system. We know there's an imbalance between pro-inflammatory and anti-inflammatory factors that regulate the immune system. So it is felt to be a Th1 and Th17 mediated disease, and there's peripheral activation of lymphocytes through these cytokines and leukotrienes and such. And then matrix metalloproteinases break down the blood-brain barrier, allowing trafficking of these peripherally activated lymphocytes into the central nervous system, where they cause inflammation and damage through various pathways such as reactive oxygen species and nitric oxide pathways and others. On the other hand, we have anti-inflammatory, regulatory factors, and neurotropic factors. So the dogma was that MS is a mainly demyelinating disease early on. So inflammation causes damage to the myelin, and that results in plaques and symptoms. The dogma was that later in disease, people can develop axonal transection and neuronal loss. But now we know that's not the case. Even in very early stages, even in preclinical stages of MS, people may have axonal transection and neuronal loss. The importance of this is that our reparative mechanisms do a decent job of remyelinating, not always perfect, but decent. But they don't do a very good job of putting transected axons together and, of course, growing new neurons. So early treatment is important because without treatment, irreversible types of damage are occurring in the nervous system, axonal transection and neuronal loss. This is a photomicrograph. The green here is axons. The red is staining to myelin basic protein. You can see there areas, arrowheads point to areas of denuded axons where the myelin has been damaged or stripped. This is an axonal spheroid which forms after axonal transection. So when the axon is broken or cut in half, the ends of it form a spheroid like that. So we know this process is occurring even in very early stages of MS. So MS, again, is an immune-mediated disease of myelin, axons, and oligodendrocytes, and other central nervous system cell types are affected as well, like astrocytes and macrophages and microglia are involved as well. I like to tell my patients, if you've seen one patient with MS, you've only seen one patient with MS. They're all different. They're like snowflakes, in a good sense. So who gets MS? Mainly, as I was mentioning, this is a disease that starts at a young age. There are pediatric cases, and there are cases in people older than 50, but probably 90% of cases are diagnosed between age 20 and 50. The mean age of diagnosis, median age, is around 30, 32. It's more common in women than men. There's almost a 3-to-1 female to male ratio, and that seems to be growing for some reason. It's more common in Caucasians than other ethnic groups. There's a polar gradient, so if you move closer to the poles of the Earth, the incidence of MS increases as compared to the equatorial regions. And we think part of this has to do with sunlight exposure and vitamin D levels. There's less exposure to sunlight in polar climates, lower vitamin D levels. We know vitamin D is a cofactor in the regulation of many genes involved in control of the immune system. These are older numbers. We think this is maybe 1.5 to 2 times as much, maybe 600,000-700,000 patients estimated in the US. There are more than 200 genes which have been identified, which individually increase the odds ratios of developing MS a tiny bit. Most of these have odd ratios like 1.1 and so forth. But we feel that if enough of these genes build up, then the patient may be at a higher genetic risk, and then the environmental factors come into play, such as, in addition to the ones I discussed earlier, childhood obesity and smoking are also associated with increased risk of developing MS. We know there's a genetic component, but it's not the classic Mendelian inheritance pattern where there's a 25% or 50% chance of passing on MS. In first-degree relatives, the risk may be about 3 or 4%. In dizygotic twins, the concordance rate is only 10%. In monozygotic twins, the concordance rate goes up to about 25 or 30%, but it's not 100%. So the genes play a role, but they don't tell the full story. How do we diagnose MS? So first of all, you have to get a really good history. The patients have to have symptoms that are highly suggestive of MS. Often patients are told MS based on nonspecific symptoms like fatigue and so forth. That can lead to diagnostic error. So again, remember the classic presentations of MS. There's optic neuritis, transverse myelitis, brainstem syndromes. People may have a cerebral syndrome like hemiplegia or hemiparesis or hemianesthesia. Those are the vast majority of patients. If there's something else, it's atypical. We really have to be careful about diagnosing MS. And then you have to do a thorough exam and elicit central nervous system findings. And then you turn to MRIs. You're looking for the classic Dawson's fingers and periventricular lesions, but lesions can be found in other areas as well. And spinal fluid may help. We have diagnostic criteria now called the McDonald criteria, which were first established in 2001. These were the first set of criteria, to incorporate MRIs in the diagnosis of MS. The latest revision were made last year. If you remember the classic med school definition, MS is 2 attacks separated in time and space. This gets you there, but there's sort of a checklist. If the patient has had 2 clear clinical attacks and you have objective evidence or really good historical evidence, then that's adequate. But sometimes patients come to you after just their first attack, and then you can use the MRI to try to diagnose MS. You're looking for dissemination in space and dissemination in time on the MRI. For dissemination in space, they have to have typical lesions in 2 out of 4 brain areas. These would be periventricular, juxtacortical/cortical, infratentorial, and spinal cord. And for dissemination in time, you have to have changes, so new lesions develop over time on the MRI, or you have to have one MRI showing asymptomatic enhancing and non-enhancing lesions. Again, typical demyelinating lesions. Remember, it's not uncommon to have small punctate, rounded subcortical lesions in patients with vascular risk factors. Even migraine can cause lesions that look like this. So not all lesions are created equal. So now you can diagnose MS with 1 attack and 1 MRI if it meets criteria for dissemination in space and dissemination in time. Also, there should not be any other explanation for the symptoms. So we have to get a thorough review of systems, and depending on that, we may order serologies to rule out conditions that mimic MS, sarcoidosis, or Lyme disease, so forth. So again, this is the rest of the criteria. Here's some representative MRIs. You can see periventricular lesions. When you're ordering an MRI, if you suspect MS, please put MS protocol, what the radiologists or technicians will do is obtain sagittal and or coronal T2 and FLAIR and post-contrast images. Those enable us to pick up these periventricular lesions much more easily. So here's a FLAIR MRI. This is sort of history. Any lesion that has occurred at any time will be seen on FLAIR and T2. FLAIR is a T2 image with CSF signal subtracted from the ventricles and the subarachnoid space. This enables us to see these periventricular lesions much more easily. This is a post-contrast image. This is an indicator of ongoing inflammation, which leads to a leaky blood-brain barrier and enhancement of lesions. This is called a T1 image. This is difficult to see, but here you can see a couple of hypointense areas. These indicate areas where there has been loss of brain substance, significant loss of neurons and supporting cells. We call these black holes. These have the strongest association with accruement of disability in the future. Here's a spinal MRI showing an enhancing lesion. Lumbar puncture may be elevated. Lumbar puncture may be useful. 90% of patients have a mild lymphocytic pleocytosis with oligoclonal bands. They may have elevated IgG index. Evoked potentials may be helpful as well to look for dissemination in space. So we can check the visual pathways, auditory pathways, spinal pathways. This way, if we don't see anything on the imaging and if we don't find anything on exam, this can show us subclinical involvement of those other regions. And as I mentioned, other causes need to be excluded. We talked about CSF. I'm going to skip that. So there are various courses or types, subtypes of MS. The most common is relapsing remitting MS. But you can think of sort of the earliest or first preclinical stage being radiologically isolated syndrome. Often we will have patients referred to us who have typical demyelinating lesions on their MRI. They got the MRI because of concussion or headaches or some other reason. And when we take a good history, they've never had symptoms suggestive of MS. On their exam, there's nothing suggestive of MS. We call that radiologically isolated syndrome. So the demyelination is only in the radiologic realm. Current guidelines are that this does not need to be treated, but we follow these patients closely. We educate them about their risk factors, symptoms, and we tell them get back to us if you develop symptoms. We see them from time to time to look for changes on examination, and we may repeat MRIs time to time to look for new lesions. Some patients present with a clinically isolated syndrome, so they've only ever had one attack. It could be optic neuritis, transverse myelitis, or a brainstem syndrome. They could have clinically isolated syndrome with low risk of developing MS, or clinically isolated syndrome with high risk of developing MS, or clinically isolated syndrome meeting McDonald criteria for MS. That depends on what their MRI shows. And spinal fluid may be useful as well. So positive spinal fluid can substitute for dissemination in time criteria. Most common type of MS is relapsing remitting. So these are patients who have relapses. A relapse is a new or worsening neurological symptom lasting at least 24 hours with no other explanation, not because of fever or infection or heat. We know patients will have, many patients, most MS patients are heat sensitive, And when their body temperature rises, their old symptoms can come back or current symptoms can get worse. And this can happen during exercise or a hot bath or on a hot day or when they have a fever or infection. So 85 to 90% have relapsing types of MS. And this is the type for which we have the most treatments. Next is primary progressive, about 10 or 15%. They just have gradual progression, gradual worsening from the very beginning. They may have periods of stability. I'll show you what these look like over time. There's only one approved treatment for this, which was approved just last year. And then there's secondary progressive. These are people who had relapsing remitting or may still have relapsing remitting, but on top of that, they develop gradual worsening of symptoms. So here is relapsing remitting. People may have increase in symptoms or neurological dysfunction. Here's the baseline. Over time, perhaps this patient developed weakness. It lasted for a while, then got better. It may resolve completely, or there may be leftover disability. In 40% of relapses, patients don't bounce back fully. In 40% of relapses, people have some leftover problems. So this is relapsing remitting. Many patients with relapsing remitting go on to develop secondary progressive MS down the road, on average 10, 15 years after diagnosis. This was the natural history data before we had treatments. Now we think with treatments, this secondary progressive phase may be delayed. So during the secondary progressive phase here, they have gradual worsening, which may be superimposed with relapses or may not. And then here's primary progressive MS, gradual worsening from the beginning, may have periods of stability, may have relapses along with that. One of our assessments of disease activity is, of course, relapse. And then there are MRI changes we look for. And then we also look for progression of disability. So we have a scale called the Expanded Disability Status Scale, which has 7 subscales, things like cognition, motor function, sensory function, vision, bowel and bladder, and such. And we score them on each of those 7 scales based on their exam and answers to our questions. And then based on those 7 scales, we give them an EDSS score ranging from 0, which is perfectly normal exam, no complaints, to 10, which is death from MS. There are some milestones along here. 3 is considered the cusp between mild and moderate disability. If they start having trouble ambulating or functioning, they're at least a 4. If they need a cane, they're a 6, and then wheelchair, and finally bedridden. So we want patients to be stable on the scale or improving. We don't like them to get worse. But this is a number, usually I score it once a year. Most neurologists, MS neurologists, do it once a year. This picks up gradual change. Relapse is a sudden change. This picks up a gradual change in their functioning. We think the reason for secondary progression is change in brain reserve. So if you think of the nervous system, central nervous system, as a pool, you have the brain here, the brainstem in the middle, and then the shallow end is the spinal cord. So the brain has the biggest functional reserve. The spinal cord has the smallest functional reserve. Now, we know MS patients have a lot more lesions than they have symptoms. So in the brain, for example, 9 out of 10 new lesions do not cause a relapse, do not cause any symptoms immediately because there's this reserve. So if you picture the lesions as being these stalactites or stalagmites, I can never remember, you can see there's a reserve. Patients are able to compensate for that. In the brainstem, the reserve is less, and in the spinal cord, the reserve is even less. So spinal cord lesions are more likely to cause symptoms than brain lesions. What happens over time is our functional reserve decreases. With aging, it occurs faster in MS patients, occurs even faster with vascular risk factors and bad habits like smoking and alcohol abuse. As a result of this, these previously asymptomatic lesions gradually become symptomatic, and so patients have a gradual decline in their functioning. That's secondary progression. And we want to prevent that, and that's where managing vascular risk factors and developing healthy habits are important. So our goals of MS treatment are to modify the disease process, prevent relapses, because 40% of relapses lead to permanent disability or increase in disability. Prevent new lesions, because they may pay a price down the road for new lesions. They may have more progression, and also to slow progression. The medicines we have work really well on the inflammatory component. They do a great job of reducing relapse rate. They're not so effective when it comes to slowing progression once it has started. But we think with early treatment, progression can be delayed or prevented. Of course, we have to treat exacerbations or relapses and manage their symptoms and promote quality of life. So I'm not going to go into too much detail with these medications, but pretty much we group them into three categories. We have injectables. These have been around the longest. And daclizumab was taken off the market earlier this year because of liver failure. But we have glatiramer, which is relatively safe even in pregnancy. It's category B. And then we have interferons. The way these work is by modulating the immune system. They promote a Th2 and T regulatory environment. Now we have some oral medications, dimethyl fumarate, fingolimod, and teriflunomide. These work by different pathways, including promoting anti-inflammatory and cytoprotective activities, blocking egress of activated lymphocytes from the lymph nodes, and having a cytotoxic effect on rapidly dividing T and B cells. Teriflunomide is pregnancy category X, not just for women, but also for men. So very important to discuss family planning with our young patients. We encourage them to use birth control, and ideally 2 forms of birth control, and we tell them, down the road, if you choose to start a family, come talk with me. We'll see how you're doing. We'll see how we can adjust your medicines before you attempt to conceive. Finally, we have infusion medications. These are alemtuzumab, mitoxantrone, natalizumab, and ocrelizumab. Mitoxantrone is hardly ever used these days because of 1% risk of lymphoma and also 1% risk of cardiomyopathy. We have natalizumab, which has a risk of PML, progressive multifocal leukoencephalopathy, which could be fatal. And the risk of this depends on prior exposure to chemotherapy, duration of natalizumab use, and antibody to JC virus. So when people are put on this, we always discuss with them, and we encourage them to let us know if there's any changes to their medicine and any change to their neurological condition, because we want to catch PML early if it happens. Newest medication is ocrelizumab, which is anti-CD20. And in the study, there were a few cases of skin and breast cancers. So again, screening becomes very important, and we encourage patients to screen themselves and to get their recommended screening, mammograms and pap smears and colonoscopies and so forth. And there's alemtuzumab, which is an anti-CD52 monoclonal antibody, which causes reduction in B and T lymphocytes. This, again, is highly effective therapy. All of these are highly effective when it comes to reduction in relapse rate. However, there are some serious considerations with this. Once they stop the medicine, patients need monthly blood work for 4 years. We look for thyroiditis. There's 1 in 3 who get autoimmune thyroiditis. 1 in 100 get ITP. 1 in 300 get basement, glomerular basement disease. And there are other autoimmune conditions also which can occur in the setting of alemtuzumab use. So this is reserved. This is actually a third-line agent. Patients have to have failed 2 first-line agents to go on that. Everything else is first-line as far as the FDA is concerned. Now, there are so many different medicines. How do we choose? Of course, patient preference. Some patients may not want an injection. Lifestyle, where they are in life. Are they going to start a family soon? All these considerations come into play. Another thing we look at is patient prognosis. So we look at the prognostic factors. Who's the patient? Generally speaking, smokers, men, and African Americans do worse than non-smokers, women, and Caucasians. Then we look at how their MS came about. Generally speaking, people with motor onset do worse compared to non-motor onset. And people who have numerous attacks early on tend to do worse than those who have fewer attacks early on. People who have fixed disability early on, so they're already walking with a limp and so forth, tend to do worse than those who recover well. And then we also look at their MRIs. The more lesions they have, the worse their prognosis. And also we look at the location of the lesions. Brainstem and spinal cord lesions indicate a worse prognosis. Remember, those areas have a lower brain reserve, or lower reserve. And also, how people do in the first 5 years of their disease tends to indicate how they will do in the next 5 years. Relapse management, so we often give steroids. We don't have to give IV steroids. High-dose prednisone works just as well. ACTH is rarely used. It's very expensive. Not all relapses are treated with steroids. If it's something mild, numbness, some vision loss, we don't treat with steroids. Excuse me. But if there is significant weakness or something that's really affecting their functioning, we will treat with steroids. If their symptoms are refractory to steroids, we may give IVIG or plasmapheresis. The symptoms are extensive. I'm not going to go over them all. We mentioned temperature sensitivity, so patients have cooling vests and cooling packs available to them. They can buy them. And I encourage them to wear them during hot weather or when they're exercising. This can improve their endurance and keep symptoms at bay. Some patients are sensitive to cold, but those are fewer than those sensitive to heat. Weakness, of course, rehab. There is a pharmacological treatment for weakness, dalfamperdine, which stabilizes nerve conduction through its effect on potassium channels. And, of course, mobility aids. Now, for fatigue, first thing I want to know is, why are you fatigued? And what do you mean by fatigued? Are you drowsy? Or do you feel lack of motivation? Maybe you're depressed. Or is it true fatigue? You just don't have the energy. And then depending on what it is, we may treat appropriately. And there are off-label medicines available for treatment of fatigue. Mobility issues, again, assistive devices, PT, and dalfampridine can help. Dalfampridine has shown to lead 30% improvement in walking speed in about 30% of patients. Bladder dysfunction can occur, and there are various treatments for that. I'm not going to get into specifics. You guys are the experts on these. Bowel dysfunction, pain. So there used to be dogma that MS does not cause pain. We know that's not true. People can have neuropathic pain in MS, and they can have pain from spasticity. People will come and ask you about medical marijuana, and the evidence is scant, but it seems to lower patients' perception of pain from spasticity, although when the physicians examined them, there was no change in their spasticity. So, of course, that's not FDA approved. And depression, more than 50% of MS patients have depression. They have a 7-time greater suicide rate compared to the general population. So very important to screen for this and treat it. Cognitive impairment, again, very common. Probably half of patients or more have this. Simple mini mental status is not a good enough screening tool. The symbol digit modality test is a good screening tool. It's a brief test. They're symbols that represent digits 0 to 9, and there's a key at the top, and the patient is given the form, and it's a time test, and we see how many symbols they can correctly match with the corresponding number. So cognitive functions affected in MS include speed and information processing, attention and concentration, memory, executive functioning, verbal fluency. So these are complicated patients, and a comprehensive team-based approach is needed, and we appreciate your help managing these patients. In addition to healthcare professionals, there are advocacy groups like the National MS Society, MS Association. MS patients are very motivated. They're very educated. They want to be involved in their care. They want to be involved in research. They have a lot of online support forums and such. All that is important, but I do tell them, don't go reading people's blogs because they may scare you. They may not be fair and balanced, and that's just a narrow view you're getting on somebody's blog. But go to a reputable website like the National MS Societies. So, as I said, there are a nationwide network of offices. There are numerous resources they have. There's a comprehensive website, phone number. They have great educational and support programs. They advocate for patients in Harrisburg and DC, and they provide financial assistance for patients who need it. So here are some of the resources, and thank you for your time and your attention. I'm happy to take any questions.
Any questions or comments, Dr. Manzi?
So Troy, I'm listening to your talk, and a lot of the demographics sounds very much like the talks I give for lupus.
Mm-hmm.
Young age, the predominance in women, the snowflake, everyone's different. And we always think of it on the spectrum of autoimmunity, and in fact it is. Are there any, have you ever looked, or has anybody looked at serologies, antibodies, like do you measure antibodies in the serum?
No, we have not found any antibodies that are pathognomonic or can be used for monitoring.
And do you know, has anybody just looked at the prevalence of ANA? Because we get a lot of these patients that have these ANAs and MS-like symptoms, and Do you know what the prevalence is?
I don't off the top of my head, but I imagine it's higher. We know MS patients are at a higher risk of developing other autoimmune conditions, and psoriasis would probably be the most common, but there are other ones as well.
Last question, not later time, but you had there that there's a higher prevalence of having first-degree relatives with MS. Do you also see first-degree relatives with other autoimmune conditions, autoimmune thyroid?
Yes. Yeah, any autoimmunity, as you know, will increase the risk of other autoimmune conditions. Yes.
That was a great lecture.
Thank you.
Just a quick question. How do you distinguish objectively between a pseudo-exacerbation and a true one in the setting of a trigger factor like an infection, which is typically the patients we see in medicine?
Right. So remember, pseudo-relapse, it has to be an old symptom that came back or an existing symptom that worsened in the setting of an infection. So first thing I ask are about signs and symptoms of infection, and I'll also often get a UA. Urinary tract infections are very common in these patients. That would probably be the most common cause of a pseudo-relapse. So if I feel there's an infection, then I'll say, all right, let's treat the infection and give it time and you should get better. If there's no infection, then we treat as a relapse. We don't necessarily have to get MRI when we suspect a relapse. But we do get MRIs time to time to look for those new asymptomatic lesions.
Can I ask another question, Mark? I'm
Sure.
sorry. So eculizumab is one of your treatments with CD20 target, and that's rituximab. Well, so no rituximab data in MS, or?
So off-label, it's not been approved for MS. There were studies in primary progressive, and they didn't meet the threshold. But subgroups within the populations had significant benefit. Younger patients and patients who had primary progressive MS but had enhancing lesions and or relapses tended to benefit from that. So yes, it is used off-label. UPMC physicians, for example, use it a lot. They were able to get it through their formulary. We have a hard time getting it. So we use more ocrelizumab, which was approved last year.
I just had a question, just sort of broadly. In your career, there's been a huge number of new medicines that have been approved just in the last 5 years. What is that doing now in terms of prognosis? Like, how are you advising your patients differently today than you did when you started your career?
This even goes back before my day. I started residency in neurology in 2006, but before that, all we had was Copaxone and interferons. There are now 5 different interferon preparations. And back then there were only 3, but they used to fight, this one's better than this one, but really they're pretty much neck and neck. Now, and interferons can have side effects like flu-like symptoms that really make people feel crappy, but they would be made to stay on it because there were no other options. But fortunately now we have a lot more options, so if something fails, we move on to the next higher efficacy medication. So we're quicker to switch treatment if patients are having side effects or breakthrough disease activity. And it's just nice for patients to have more choice, more options. We didn't have any oral medications till 2010. They were all injectables, and there was one infusion, which was monthly. So imagine coming to the office once a month to get an infusion if you're working. People blow through most of their vacation that way. So it's just changed a lot as far as convenience and choices and not having to put up with terrible side effects. We can treat them more aggressively now because we have more choices. Thank you all.